Hello and welcome to IBD School. My name is Leslie Aldrich and I'm an IBD specialist at the University of Michigan. In this video, IBD School 806, we'll talk about pregnancy and delivery in IBD. Specifically, we'll talk about delivering a baby with intact intestines versus with a J-pouch or ostomy. In general, IBD patients tend to see high-risk obstetricians and are labeled as potentially at-risk patients for complications during pregnancy or birth. This risk has more to do with the patient potentially dealing with a flare or active inflammation during their pregnancy and/or delivery, and not to do with the risk of maternal distress, miscarriage, or more birth-related trauma. IBD patients are no more at risk for these than anyone else. If you have IBD and your intestines are all intact, you will be able to give birth just like anyone who does not have IBD. Only in rare cases, when a patient's IBD is out of control, when they are nearing delivery, may a physician elect to perform an early cesarean in order to avoid over-medicating a patient while they are still carrying a child. However, this is rare, and in nearly all cases, you will still be able to give birth vaginally without complications. You can also consider alternative birth methods like water birth and other home birthing methods. We generally recommend avoiding an episiotomy if possible. An episiotomy is sometimes performed by an obstetrician before birth, but it increases the risk of a tear in the anal sphincter, reducing control of the bowels. Because control of the bowels is so important to patients with IBD, it is important to avoid an episiotomy if possible. The most common change in delivery or birth method in IBD patients is the election to perform a cesarean section rather than a vaginal birth when delivering the baby. A cesarean section will be safer than a vaginal delivery in certain given cases. When a patient is experiencing a severe flare, if a patient has Crohn's disease with perianal complications like fistulas or abscesses, or if a patient has a J-pouch or ostomy. In these cases, your physician will likely elect to perform a cesarean section to promote the health of both the patient and the baby. C-sections for patients with IBD are more common because of the dangers posed if a patient has tearing from the vagina to the rectum, which is a possible occurrence during vaginal childbirth. Perianal disease is a common occurrence in patients with Crohn's disease and may include problems with fistulas around the rectum, which are tunnel-like connections from the bowel to the skin around the rectum, infections, or narrowing of the anal canal. Vaginal delivery can be associated with worsening of active perianal disease after delivery. Also, active perianal disease is strongly associated with the risk of developing a tear in the muscles of the rectum during vaginal delivery. It is for this reason that your doctor may recommend a C-section. For patients who have undergone J-pouch formation, your doctor might also recommend a C-section to prevent injury to the muscles of the rectum. If you are pregnant and need surgery before you deliver, do not put off urgent or necessary surgeries simply because of your pregnancy. However, if a surgery is not urgently needed before you give birth, you should wait until after you deliver to have intestinal surgery. Having IBD should not be a deterrent to becoming pregnant. No matter your situation, as long as you stay informed and communicate with your physician about what birth method will be the safest for your body and your symptoms, you should by all means have a successful and safe delivery. I'm Leslie Aldrich, and thank you for watching IBD School.